Recently, with improvements in technology, there has been a significant increase in the use of flexible ureteroscopy in the treatment of renal calculi. In this video, we present the initial clinical experience with a novel, flexible robotic system for performing ureteroscopic holmium laser lithotripsy for select patients with renal stones. The novel robotic system from Hansen Medical, primarily designed for intracardiac applications, was modified for use in the renal collecting system. The robotic system has the following components. The flexible effector consists of the inner guide, outer sheath, and the ureteroscope, the surgeon console, the robotic arm, and the electronics rack. The various components are integrated as shown in the picture. The robotic arm or remote catheter manipulator is fixed either on the operating room table or on a floor stand. The flexible effector consists of an outer sheath and an inner guide with an external diameter of 14 French. The inner guide moves actively and the outer sheath maintains stability. The flexible effector has 4 degrees of freedom and can be effectively manipulated in any direction in space. The flexible effector has a maximum deflection of about 260 degrees in all directions. The passive fiber optic ureteroscope is passed through the inner guide and controlled by the robotic sheath. The surgeon manipulates the flexible effector tip comfortably seated at the console away from the radiation field. There are 3 screens on the console that provide continuous endoscopic and fluoroscopic views. Various controls at the console include sheath bend and auto retract, which help the surgeon in performing the procedure. The unique 3-dimensional joystick, also known as the master input device, provides remote instinctive control of the flexible catheter tip. You can see here the precision at which the catheter can be manipulated. The rings in the video represent the pulmonary valves. The robotic system also has the ability to incorporate preoperative imaging to aid navigation. In this video, you can see real-time intraoperative imaging on the right and navigation of the virtual catheter in a preoperatively performed 3D CT reconstruction of the heart on the left. This capability can also be extended to the renal collecting system with existing technology. In the present study, we performed robotic ureteroscopy and laser lithotripsy in 18 patients with renal calculi after obtaining IRB approval. All patients were pre-stented for a period of 2 weeks. Any patient with present or prior ureteral obstruction were excluded from the study. There were 8 right and 10 left renal calculi. 5 patients had more than 1 stone. Mean stone size was 12 millimeters. The stones were located in various locations, with 12 patients having lower pole stones. The procedure began with placing 2 guide wires cystoscopically after removal of the double J stent. The 14 French catheter system consisting of the inner guide and outer sheath was manually inserted with the aid of a tapered obturator under fluoroscopic control. Once positioned within the collecting system, the obturator was substituted by the ureteroscope. Stones were then located and then basketed into a favorable location as required and fragmented into small gravel. The first case is a patient with a 1.2 cm left lower pole calculus. A retrograde pyelogram demonstrates that the stone is at a difficult and acute angle to the lower pole infundibulum. The outer sheath and inner guide are being inserted. The assembly is introduced till the tip of the outer sheath is positioned just at the UPJ. The robotic system can be easily maneuvered into this tight lower pole location under endoscopic and fluoroscopic control. The stone is visualized and entrapped using a 3 French nitinol basket and is easily relocated into the upper pole. Fragmentation using holmium YAG laser is then commenced. A retrograde pyelogram is performed at the end of the fragmentation to confirm collecting system integrity. A double J ureteral stent is positioned routinely, and post-operative CT scan at 2 months in this patient shows complete stone clearance. The second case is a patient with a 10 mm left lower pole calculus. The robotic sheath and guide are inserted after removal of the stent under fluoroscopic control. The lower pole stone is clearly seen. The lower pole stone is grasped using a nitinol basket and relocated into the upper pole calyx. Laserlithotripsy is commenced. The robotic system allows precise stone fragmentation using the 365 micron laser fiber. Post-operative imaging confirms complete stone clearance and absence of any ureteral stricture based on intravenous urography. The mean total operating time was 90 minutes. The mean robotic docking time was 7 minutes, with it being consistently less than 5 minutes in the last 10 cases. Total time on robot for navigation and fragmentation was 41 minutes. The mean stone localization time was 9 minutes, again being approximately 1 minute for the last 7 to 8 cases. The system demonstrated efficacious control rating, stability of navigation, and ease of fragmentation on a visual analog scale. The stone clearance at 2 months on CT scan was 56%, and based on KUB at 3 months was 89%. A secondary ureteroscopy was required in one patient with a residual stone. Complications included pyelonephritis in 2 patients, unexplained fever in 1 patient, and a temporary limb paresis in 1 patient. In our opinion, potential advantages of the robotic system over manual ureteroscopy include improved maneuverability, increased active degrees of freedom, stability of the tip, possibility for automated movements, the ability to incorporate imaging modalities, ergonomic superiority, and the avoidance of radiation to the surgeon. Cost effectiveness of this new technique needs to be evaluated. We still need to define the optimal size of the catheter. The optics need to be improved, and there should be integration of accessories such as laser and baskets into the catheter system. To conclude, remote robotic flexible ureteroscopy is technically feasible, and we herein present the first clinical experience for treating renal calculi using this technology. Further clinical data are required to demonstrate advantages over manual ureteroscopy. This may prove to be an ideal platform for flexible endoscopy in general.